Hey everybody, it's Rob Casquejo in the Dermcast studio, and welcome to Dermcast TV. We have a very special guest today. Those of us who practice dermatology, we don't get a ton of exposure to pediatric dermatology, and thankfully today we have an expert in the subject. So welcome today to Dr. Lisa Swanson. Hi, Dr. Swanson, how you doing?
Hello, I'm doing great. Thanks for having me.
Well, thanks for taking time out with us in Dermcast TV. And we'll get right to this because I'm sure that our viewers have a lot of questions for you. We're going to try to talk about this from a mile-high view of pediatric dermatology. So speaking of a mile-high view, pediatric dermatology is very different than adult dermatology. So give us a hint on how to approach pediatric dermatology versus adult dermatology.
Yeah, I think the first thing is definitely have some suckers in your office and definitely have some prizes that you can bribe children with. Those are the two golden rules of pediatric dermatology: suckers, prize box.
I like it.
Um,
Hey, sometimes it works for adults too. I mean,
It's true. It's true. It's true. And so, having things for the kids to do in the office is also really helpful. We have coloring sheets and crayons. We have some little toys and things in the exam rooms, things that are easily cleaned, of course, during the age of COVID, but things to keep them busy, keep them occupied, let them feel comfortable so that they aren't nervous and worried the whole time. And so it gives me the opportunity to have a conversation with their parent without the child just kind of being distracted or, running around like crazy. It just gives me the time to focus on mom, have a good discussion with mom and or dad, and discuss their child's skin condition. So I think having things for them to do, making it feel like a welcome, friendly place. We have little pictures of Frozen all around. Who doesn't like Frozen?
oh,
Everybody
I'm
likes Frozen.
huge fan, huge fan.
Yeah.
Olaf, come on, who doesn't like Olaf?
I know, Olaf, I know. And so, things that make them feel comfortable are important. And I always start a visit as long as the child's like age 3 or 4 or above. I'll introduce myself. I'll make sure that I have their name correct and ask if they have any nicknames. And then I'll actually ask the child what brought them in today, because it gives you a good sense for that particular kiddo. Some kids really like it, are totally into it, and will give me an excellent clinical history of why they're actually there. Others get really shy, but that's okay too. And then I'll say, do you want your mom to tell me? And they'll say, yes. But it includes them right off the bat. And sometimes it allows for a great deal of humor in the exam room, because sometimes I ask them what brings them there today, and the answer is hilarious.
That's great. That's so useful because we develop relationships with patients, and why not with the children? They are the patient. That's great advice. So that's fantastic. Just taking the broad approach to the patient. So I think this is an important thing to ask. A lot of times we struggle with the issue of biopsying lesions, dermatoses, etc., in children. This can be an issue because of comfort. Sometimes the parents' fears are written into this, and maybe even starting certain therapeutics. So specifically, let's say a biopsy. Are there pitfalls here? Are there scenarios where you should sort of live to fight another day? Or do you really feel like if a clinician is in a position that this needs to be biopsy, you just go for it? Do you have a feeling on this?
Yes, definitely. So I think that pediatric dermatologists really pride themselves on being excellent clinical diagnosticians, especially with like rashes and things. We really try to figure it out based on the clues in the history and the way the rash presents or the spot looks. And it's a source of personal pride to us, almost so much that if I do need to biopsy something, I'm kind of disappointed in myself. It's like, Lisa, you should be able to look at this and tell what it is for sure. And so I think we do work really hard to try to just be really excellent clinical diagnosticians, and so that we aren't having to biopsy kids. But sometimes we do have to. Either it's a skin lesion that we're worried about. A melanotic melanoma does happen in kids, especially in younger kids. It's more likely to present as kind of a vascular looking thing or wart-like spot. And so that is crucial that you biopsy that and figure out what's going on. And sometimes rashes are a big mystery, and a little punch biopsy is going to help us a great deal. So sometimes we do have to do it. I think that I tell the patients that I'm going to walk them through every step of the way. I'm going to warn them before I do anything, and that I'm going to be honest with them. I'm going to tell them what's going to hurt and what's not going to hurt. And really, there's only one little part that hurts, and it's going to be over very quickly. I tell them we have a prize box that they're going to choose stuff from afterwards. I tell them that they're brave enough to get through this, and they can tell all their friends and siblings about it afterwards and brag about how brave they were at the dermatologist's office. So I try to build them up, but also be reassuring that I'm going to walk them through this, and it's not going to be a bad thing, and we're going to get through it, and they're going to do a great job. If that just really isn't going to fly, and to do a biopsy is going to turn into a very traumatic experience for everybody involved, I fortunately have the capability at my local children's hospital to do things under anesthesia. So if it's really important that we remove a spot or biopsy a rash, and it's just, maybe it's the location or the age of the child, or maybe they have some disabilities, maybe they're on the autism spectrum and I can't clearly communicate and warn them what I'm going to do, and have them understand. So, I have that option if I really need to do a biopsy and it's just not going to fly in the office. And that's something that I'm lucky to have.
That's great. So, we're like that with adults. I mean, these things happen at certain levels with adults. It's probably just a little bit more understood with adults. But with kids, I'm hearing being forthright. First of all, be an accurate clinician, which is what we're trained to do anyways, children and adults alike. Secondly, to communicate expectations realistically of what's happening, and then communicating with reassurance. Those are all great tips. Awesome, thank you. So this leads into, go ahead, Dr. Swanson.
Well, I was just going to add one other tip regarding biopsies. If a teenage boy or preteen boy needs a biopsy, I would encourage everybody to give them a snack afterwards, because it's a rule in my clinic. I do it for all the boys, because teenage boys, preteen boys, they have a tendency to pass out afterwards. And it doesn't happen in the exam room. It happens in the waiting room as they're walking out, or in the parking lot.
Definitely, I've seen this. I've seen this in practicum. Yes, it happens.
And they just hit the ground. And so I instituted years ago a mandatory snack policy for all boys having biopsies. And since then, I haven't had anybody pass out. So we give them a snack, we give them some juice. It gives them the time to just let the adrenaline kind of flush out and dilute itself. And they can do so while they're seated, get a little blood sugar in their system, and it seems to work like a charm.
That is fantastic insight, because then you also don't want to be stitching someone together, before they leave the office visit. So that's great. And so in terms of making a biopsy tolerable for children, it's the anesthesia part that is problematic. Any tips there? What do you like to do?
So, I definitely tell them, like, this is going to hurt for like a second or two, and then it's going to be over. And so I preface that because I think it's important for them to know that the pain is not going to last a really long time. It's just a second or two. There's one thing that I sometimes find helpful during numbing or during like shots, medications that come in shots. And we tell the kids to picture a really, really big birthday cake, like the biggest birthday cake they've ever seen in their life. And that birthday cake has tons and tons of candles on it. And I say, how many candles do you see? And a lot of times the answers are so funny. I build it up. I'm like, tons of candles. And then I'm like, how many candles do you see? And they'll be like, 3.
That's funny.
I'm like, picture bigger.
It's perspective.
Right. Yeah. And then I say, okay, now on the count of 3, I want you to blow out all those candles, and you're going to have to blow pretty hard to get them all out. Are you ready? And they'll say yes. And I'll say, okay, count of 3. 1, 2, 3. And they'll say, blow, 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 blow. And while they're doing that, I'm doing the shot.
That's great.
And it works a lot of the time.
Distraction theory. Sometimes you have to do it with adults.
Yeah.
So that's great. That's great advice. I never heard it explained, that graphically specifically. That's fantastic because you
Yeah.
get them mentally engaged in what's going on. So how about things like vibratory tools, distraction tools like that, T-bars or these types of things?
Yes, so I have a Buzzy. A Buzzy comes as a bee, a ladybug, or just plain black. And it vibrates, and it has a little area where you can add a cool pack as well. So you can do ice and cold. And you're supposed to, or I'm sorry, ice and vibratory. And you're supposed to place it on the skin between the brain and the pain. And so, I use that sometimes. I probably went through a phase where I was using it a lot. I think it helps some kids. Some kids don't like the vibration. So it's a mixed bag. I still have it. Sometimes I'll use it. But I think it's a mixed bag. It's not like magic. And to your point about distraction, most families, when they're in the office, they have a phone or an iPad. And so getting a game or a video or something like that on there is always a good idea.
If all else fails, pull out the pad or the
Electrons.
phone. There you
Yes.
go. All
Yes.
right. So I think this goes hand in hand with the idea of this happens all the time in general dermatology for pediatrics. I'm sure we've all seen it, where you have benign lesions in children that are often treatable, like the viral lesions, molluscum, verruca, classic verruca, even things like hemangiomas. So sometimes there's this question again between patient comfort and a therapeutic goal. Uh, um, is the methodology, is the outcome worth the methodology? Any pitfalls or any advice there? Is there something in terms of that you like to adhere to in terms of figuring out, all right, I should treat now, or I should wait, etc.?
Yeah, yeah. So I'll start with warts because I see those, of course, very commonly. And I have a great tip on what to use for them that's painless. It's a prescription topical. It's made by a pharmacy in Iowa called New Cara. They mail it straight to the patient's house. It works 98% of the time. It doesn't hurt. It works fast. 3 to 4 weeks, you've got your warts gone. It contains salicylic acid and 5-FU in a proprietary vehicle. And I think there is something magic about that vehicle because other compounding pharmacies have tried to recreate the magic that is wart peel. And I've never seen another product work as well. And it's applied every night at bedtime. It comes with sticky tape you put on top of it, and it really just works great. It's my all-time favorite treatment for warts. And if a patient has like 30 warts, you don't have to put the medicine on every single wart. The 5-FU helps to trigger an immune system response, so you can treat the ones that are most burdensome or biggest or most noticeable, and just let the immune system get triggered and respond to get rid of the rest. And so I would say 95% of the time when I'm treating warts, I'm using wart peel. My second favorite treatment for warts is probably Candida antigen injection because you only have to treat one of them. And so let's say a patient has 20 warts and they have one or two that are on like their forearm or their knee, someplace that's really not going to be painful to inject. I like that. And it's good for the patients that know they're just going to be really bad at using an at-home medicine. And they would just rather come into the office every 3 to 4 weeks for a shot. And what I tell them, I say, it's every 3 to 4 weeks. We just have to treat one. And it typically takes 3 to 5 treatments to have them gone. So that's probably my second favorite treatment. It is rare for me to freeze warts. I really rarely do it. I don't think it works as well as wart peel and Candida. I just think the other treatments are better.
And speaking from experience, I've had it done. It is not fun. So
Yeah,
I can truly empathize with patients when they take their cryo treatments because I've had it done before and it's not fun. Well,
totally.
that's fantastic. Thank you so much. So let's talk about your specialty is pediatric dermatology. So what is out there for those of us who don't have the exposure? What's new in pediatric dermatology, diagnostics, therapeutics? What's going on out there?
So much, Rob, so much. It's so exciting to be a pediatric derm. Well, it's exciting to be in derm, period, because we got a lot of stuff going on that's really, really great, that's really helping people live better lives. And so all of it is wonderful, but pediatric dermatology is my heart. I love it. It's my passion. And so we're living through some really very exciting times. We got the approval of Dupixent down to the age of 6 months last week. That is huge. Dupixent is a medicine that we're all familiar with. It's been out for over 5 years. The indication kept getting younger and younger and younger. And it's really, really cool to see it go down to 6 months. And I think even if you're in your practice, you're not going to do Dupixent in a 3-year-old. I think it's heartwarming and reassuring to all of us to see any sort of medicine approved down to the age of 6 months. I mean, that's pretty
Absolutely.
impressive. And so that's a confidence builder for providers, a confidence builder for patients that are considering it as a therapy. This medicine is so safe, we can use it in a baby. And that really speaks volumes. What else is new in pediatric dermatology? Propranolol continues to be awesome. It's not really new, but I always like to bring it up because I think a lot of people may have not gotten exposure to it and might be a little bit afraid of it. And it's really a wonderful, wonderful medicine that is so safe and so effective. And when I give my talks at meetings, I really try to empower people to get comfortable with it, and I can help them do that. I always include my email addresses in my talks because I'm really happy to walk people through it. It's a wonderful, wonderful treatment, and there are so many hemangiomas that need to be treated that go untreated simply because the patients live in an area where maybe they don't have access to a provider that's comfortable with it. There
So
are only
you're
300.
talking about this in context of treating hemangiomas.
Yes,
Yeah.
yes. There are only 336 pediatric dermatologists in the entire country. So we're stretched pretty thin and we can't always be there for every hemangioma. And so I really try to encourage and empower people to learn about propranolol, get comfortable with propranolol. I can help with that because it's really great. And then one other thing that's quite new, there was recently a medicine approved, a pill approved to treat limb overgrowth syndromes. So things like Klippel-Trenaunay. And we have never had therapies to treat limb overgrowth syndromes. And what a burden these patients live with. It's really a bummer. And so to see a pill approved to treat these patients is really profound and amazing. During my talk, I plan to share some before and after pictures of the patients involved in the study, and it'll take your breath away. These overgrown limbs actually shrinking in response to a pill. It's pretty great.
That's very exciting. So, looking at the broad array of things in pediatric dermatology, and I think a lot of us get a little apprehensive because, all right, I don't want to miss something. So if you were to talk about a couple things that you just don't want to miss in general in pediatric dermatology and a pediatric skin exam, what would you say in terms of you can't miss these things?
Yeah. I would say a couple of things. Number one, it's uncommon, it's rare, but we do see pediatric melanoma. And just like any melanoma, you don't want to miss that. In kids under the age of 12, it's more likely to present as a pink, crusty papule, something that you might want to call angiokeratoma, where there's kind of a pink vascular appearing papule, crusty surface. It can mimic a pyogenic granuloma. It can mimic a wart. And so in kids under 12 with these somewhat amelanotic, maybe atypical presentations for melanoma, it should be on your radar. I remember when I was a fellow and I went in first to see a patient, she was 3 years old, and she had this vascular appearing papule with a crusted surface on her shin. And I went back in to tell my mentor and hero, Ron Hansen, about the patient. And I said, I described it and I said, maybe angiokeratoma. And he said, maybe, but we're going to biopsy that because that's what juvenile pediatric melanoma looks like. And so I think that's something definitely don't want to miss. The other thing I would say would be hemangiomas that are at risk for ulceration, or certainly hemangiomas that have already ulcerated. Something needs to be done for those hemangiomas because that is a horrible, painful experience for the patient and their family. And we know that certain areas are at increased risk for ulceration, like the lip and the diaper area. And so treating hemangiomas that are at risk, certainly treating if the hemangioma is already starting to ulcerate, that's something I would say, please don't miss that.
And is
The babies are sad, they
propranolol
cry a lot.
great? And is propranolol your go-to in those scenarios? Great.
Yes, propranolol is my go-to in those scenarios, and it works well and it works fast. And yes, definitely.
Okay, fantastic. Well, that is great information. We could, 300 and some odd pediatric dermatologists. I had no idea it was that small of a group. So you're not
Yes.
just an expert; you're like a super expert. This is great. Yeah.
Yeah, I like to say I'm a unicorn.
I would say, I mean, with that number, I would say you're that and much more. But thank you so much, Dr. Swanson, for taking time with us. We appreciate so much your support of the SCPA and dermatology physician assistants. Your advice and your lectures, your academia are very well appreciated by myself, and I'm sure that I'm speaking exactly the same for my constituents, my peers, and for the organization. Thank you very much for joining us, and I hope we can do it again sometime. We'll talk about some other things that come up new, and I'm going to make sure I catch some of your lectures, and maybe we can talk about some other cool stuff as well.
That sounds awesome. Thank
Well,
you.
you have a great rest of the day, great weekend, and everybody, thanks for watching Dermcast TV. It's Rob Casquejo.